Welcome to Raaonline. Today we are going to see about interpretation of ventilator waveform. So we all know about G electrocardiogram. From this ECG will record the electrical manifestation of the heart. It gives idea about what is going on within the heart, like physiological activity and some disease activity, arrhythmias, all we know from the ECG. Like ECG, ventilator, nowadays the modern ventilators will give the continuous real-time information about patients and ventilator interaction about respiratory mechanics. So most commonly we will see the three waveforms. One is that pressure time scalar, flow time scalar and the volume time scalar. From these informations we can understand what is going on within the patient's lung, how can we adjust the ventilatory parameters, how can I optimize the ventilatory settings to improve the patient ventilator synchrony. So when you see here, but this is the most important, understanding of the ventilatory waveforms are very important to increase the success rate of ventilator related outcomes. But the recent survey showed that it's what published in the 2024, they found that only less than 5% of the ICU consultants are understanding the ventilator waveform appropriately. Almost more than 90% of the ICU consultants are the doctors practicing critical care, not able to interpret the ventilatory waveform appropriately. They are not making appropriate intervention for the whenever they are facing the problem with the ventilators. So the understanding of the ventilatory waveforms are very important. So next we see that what are the things, what will you do with the ventilatory waveforms, why we need that ventilatory waveforms, why the modern ventilators will give the continuous information about the respiratory mechanics. From these ventilatory waveforms, we can understand that what is the pathophysiological process. Like whenever the patient comes you with COPD related, the waveforms will be different, like the auto-PEEP or increased time constant. These are the common problems we will face with the patient with obstructive aortism. If it is ARDS, time constant will be very short. It is a compliance related problem. Our ventilatory settings will be different. So that one. Second thing, recognize the change in the patient condition. So the patients in ICUs are very dynamic in nature. For example, complaints may be normal in the morning, may be worsened during that ICU stay in the afternoon. So pulmonary edema, whatever, they're just simple aspiration. So we can recognize the change in the patient conditions from these ventilatory waveforms. From these information, from the patient change in the condition or pathophysiological process, we can optimize our ventilatory settings. Maybe treatment also we can modify. Example, patient with increased auto-PEEP or increased time constant is a resistant related problem. Some of the COPD patients may need nebulizers or bronchodilators. We can optimize, we can solve new treatments based on ventilatory waveforms. So then we can, that other things are, we can detect the adverse effect of mechanical ventilation from these ventilatory waveforms like auto-PEEP, we already told them. Based on these informations, these appropriate ventilator settings, we can minimize the risk of ventilator induced complications. So then first, how will you read the ventilatory waveform? There is first step is that what is the ventilator is programmed to do, which means that what mode of ventilation you selected for the patients. What is mode actually? What is a mode means that it gives the information about, it's gives a predetermined pattern of interaction, which means if example, if it is a volume control, your flow will be constant irrespective of the patient resistance and the complaints. If it is a pressure control, where the pressure will be, you will set the pressure on the ventilator, it will be the constant irrespective of the patient resistance and complaints. So first thing is that you should know what is the mode, how that mode actually behaves. This is very important for us. It's a step one when you start the reading of the ventilator waveform. Second thing is analyze the waveform or read the patient's physiology. So whenever that, next you see selected the mode, you know the node, then you look for the ventilatory waveform. From these waveforms, we should know that what normally this mode of mechanical ventilation, what will be the normal waveform. When any change in the resistance and the elastance, how will you affect the waveform? So this is step 2. It's analyze the waveform to read the patient physiology. This is actually called as a determine the load. Third is the patient ventilator interaction. It is called asynchrony, synchrony or dysynchrony. So we can identify from that. Based on these information, we can optimize the mechanical ventilation settings. First thing is that we should know what the ventilator is programmed to, which means that what type of mode. Second is that analyze the waveform to read the patient physiology, which means that you have to understand what is the predominant load, which is resistive load or elastic load and the step 2. Step 3 is that is there any asynchrony or synchrony or dysynchrony, you have to identify that. These are the 3 steps of reading of the ventilator waveform. First step is selecting the appropriate mode. But what is the mode of mechanical ventilation? But there is a multiple problems with this. There is almost more than 250 modes are available in ventilators. It's a problem. Second problem is that each manufacturer is giving the different names. So it's very confusing. That is, a name is actually not expressing the actual behavior of the mode. For example, the pressure regulated volume control, one manufacturer is labeling as a pressure regulated volume control. Other manufacturer, they are saying it is a volume control plus. Other manufacturer is saying it is a volume autoflow. But all these are actually working, behaving like a same actually. So, but it is like a different name. If like say a paracetamol. The paracetamol is a generic name that some people that manufacture it is a Dolo 650, Dolo 500, some tell the para P50. So, but it's very confusing to that. So, for they said replacing the mode, they said that they have to, whenever that before assessing the ventilator waveform, you have to tag. Tag means that there is a common term. It is like taxonomic attributed grouping. In this actually 3 variables to that. So, in this based on 3 variables, you will give a tag for the each mode of mechanical ventilation. The first one is that control variable. Second is a breath sequence. Third is a target scheme. Control variable means that any ventilator can control only one variable at a time. For example, your pressure control means your control variable is pressure. If it is volume control means your control variable is volume or flow. If it is a pressure support means your control variable is pressure. So, but the ventilator cannot control 2 variables at a same time. So, the control variable means that your pressure control means pressure is your control variable, volume control means volume is a pressure control variable, your pressure support means your pressure is a sub control variable. This is the first one. Second thing is a breath sequence, which means that what is your breath? It is a controlled mandatory ventilation or intermittent mandatory ventilation, or it is a pressure spontaneous ventilation. This is called breath sequence. Third one is a targeted scheme, which means that each ventilator will target some parameters. Some will target as a auto PEEP, some will target as a inspiratory flow, some will target as a inspiratory pressure. So, it's very, you have to understand these 3 variables, then only we can give the tag. First, that I've already discussed the control variables. Most likely it's a pressure control. Pressure is a control variable means it's a pressure control. Volume is a control variable, it's called volume control. Next is the breath sequence. The breath sequence, already told, it's a continuous mandatory ventilation or intermittent mandatory ventilation, or it is a continuous spontaneous ventilation. You have to mention your tag. Third one is a targeted scheme. So, targeted scheme means the ventilator will target some parameters. For example, if it is a set point, dual, biovariable, servo, adaptive and optimal or intelligent. For example, set point means all targets set by the operator. All these modes, example, volume control, pressure control, all these you will set a volume in the volume control, pressure in the pressure control. These are all set by the operator. So, it's called that volume control or pressure control targeted scheme is set point. Other method is ventilator switches from the one mode to other mode within the breath, that's called a dual modes. The third, this is most commonly, it's a PRVC. Ventilator adjusts the pressure to meet the tidal volume target. That's called the PRVC, what is most commonly there. So, it's adaptive mode. So, how will you tag the mode? First thing is that control variable. It is a volume control or a pressure control. If example, I'm talking about the pressure control. In the pressure control, my control variable is pressure. So, first I will write a pressure. Next, the breath is continuous mandatory ventilation. So, CMV. In the targeting scheme, all these pressure control, the pressure is set by the operator. So, it is a set point in the targeted scheme. So, I will label as a PCCMVS. This is actually a pressure control, what we commonly tell. So, PCCMVS means that pressure control variable is pressure. It is a continuous mandatory ventilation. Set point, targeted scheme is a set point. The volume control, my volume is a control variable. So, VC, it's intercontinuous mandatory ventilation. Set point is the targeted scheme is S. So, we label as it's a VC CMV In the pressure support mode, what we call the pressure support mode? It's a pressure support. What are the things we will set? Your pressure support, P and FiO2. This commonly will set. So, in this FiO2. So, in this mode, in the pressure support mode, my control variable is pressure. It is a continuous spondatory ventilation. So, the breath sequence is CSV. My set point is, I am setting the pressure here. So, it is a set point. So, my pressure support, commonly we will call it as a PCCSVS. This is the first thing. From this tag, we know that how the ventilator will give the breath. Then only we can interpret the ventilator waveform. The first step of the reading the ventilator is identifying the tag. Second is that determine the load. Before going to see about the determine the load, you all should know about the equation of the motion. So, we already discussed multiple times. The first equation of the motion is a mathematical equation. In this, normally lung is a multi-compartment model. For this simple explanation, we are taking a single compartment model. Here, this is your airway. This is your lung. So, whenever you are delivering a breath to the patient, positive pressure ventilation, this is called the delivering pressure is called P vent. P vent. If the P vent has to overcome your resistive pressure, this airway will give some pressure against this flow. This is called resistive pressure. Resistive pressure is here. This is R is a resistant, V is a flow. So, these are the R into V, the resistant into the flow is give the resistive pressure. It has to overcome this resistive pressure. Next is the elastic pressure. Elastic pressure from the lung and the chest wall. It has E is the elastance, V is the tidal volume. So, the P vent is equal to your elastic pressure and the resistive pressure, then only flow will occur. So, it is called equation of the motion. When my patient taking spontaneous breath with P vent, P vent is a ventilator setting, my patient is taking spontaneous respiratory effort also, then P must will come. If my patient is on both I started on ventilation, sedated and paralyzed, patient came out from the sedation and paralysis, then patient will take some respiratory effort, spontaneous respiratory effort. So, the giving pressure is both P vent and the PMS. This both the pressure has to work against the elastic pressure and the resistive pressure. So, what is determine the load means that what is the predominant load in the patient ventilator interaction. If example, in the COPD patient, what is the predominant load here? It is a resistive load, COPD. If it is a ARDS patient, what will be the complaints will be very low, it is a elastic load will be a predominant. So, from these ventilator waveforms, we get to know what is the predominant load. PMS means the patient taking a spontaneous respiratory effort. This means the PMS is there or not. So, first you have to tag the mode, next you have to see the ventilator waveform. From this ventilator waveform, you should know what is the predominant load. Is a resistive load or elastic load, or it may be the patient taking spontaneous effort. Okay. First thing is how they determine the load. So, already we discussed about the equation of the motion. It is a P vent equal to is a resistive pressure is a resistant into flow plus elastic pressure elastant into tidal volume. P vent. So, all these waveforms, most commonly what are the waveforms we will see in our ventilator screen? It is a pressure time scalar, this is a valve flow time scalar, this is a volume time scalar. From these scalar, what is actually these ventilator waveforms are expressing our same equation of the motion. Your P vent is your pressure, this is your pressure waveform is expressing your P vent. The resistant and the flow, it is actually expressing your flow waveform, flow scalar is expressing your resistive pressure. The elastic pressure is elastant in the tidal volume, is this volume scalar actually expressing your elastic load. So from these, actually the ventilator waveform or pressure or volume or flow time scalars actually expressing your equation of the motion. First thing that before going to see what is a predominant load, that's something you have to know what to that. Pressure volume control means there is a two types of flow waveforms are there. One is a square flow wave, so it's a ramp flow wave. In the square flow waves, your flow is to be constant throughout the inspiration. In the ramp flow wave, the flow is very high peak at the initiation of the inspiration. Then it is to be slowly decrease and reach the zero flow at the end of the inspiration. Okay. In the pressure controls, is the flow pressure is to be constant. Okay. So in the volume control mode, your volume is the independent variable, irrespective of my resistance and compliance, the volume will be constant, flow and volume will be constant. Here, whatever the resistance or compliance, my flow and the volume will be constant in the volume control. Okay. So I want to know patient's resistance or compliance or the highest load, it's a resistive load or volume load. In the volume control mode, I have to see those changes in the pressure. So I want to know about the resistance and compliance in the volume control mode, I have to see the pressure time scalar. In the pressure control wave, the pressure is to be independent variable. It is set by the operator in the ventilator. Irrespective of my resistance and compliance, the pressure will be constant. So if I want to know the resistance and compliance, I have to see the flow waveform and the volume waveform. So in the volume control mode, you will see the pressure time scalar. In the pressure control mode, you will see the flow and volume scalar. This is very important. So we'll just start with the volume control mode. So is there any volume control mode? Means the first thing is tag. Volume control is the volume is the control variable. So we see it's a continuous mandatory ventilation. This is the targeted scheme is yes. So first I giving the tag name to that volume control modes. Volume control, continuous mandatory ventilation. It's a targeting scheme is set point. So my flow waveform is square flow. So the volume control wave, I have to see the resistance and compliance in the pressure waveform because the flow and volumes are independent variable. So when you set that volume control, what are the things you will set? Tidal volume, respiratory rate, I ratio and FIO. These are commonly you will set in the volume control mode. In the volume control mode, the valve flow and tidal volume is constant. So at the start of inspiration, the flow will reach the maximum, that is a constant flow. Whatever I set as 60 liter based on the tidal volume and inspiration time, my flow is a 60 liter means at the start of inspiration, the ventilator will reach the 60 liter of flow. It sustains that 60 liter flow during the whole inspiration and its end during the whole inspiration. That is because then the volume control, the flow is a constant. Okay. For example, whenever the patient is the single compartment model, this is our airway, this is your lung. So during the flow occurs during the flow, it goes through the airway, then reach the lung. The first when you going to the airway, some resistive pressure, that the flow has to overcome the resistive pressure. The first pressure it's coming actually, it's a resistance because there will be a lung is not filled with that at the initiation of the ventilation. Once the lung is not filled here, there is a flow is reached 60 liters. This is the first pressure is generating is predominantly contributed by it's a resistance. Once the alveoli started to filling, the volume is started to increasing, my pressure also started to increasing. Okay. Here once the alveoli started to filling, the pressure is contributed by the both. It's a resistant and because there is a continuous flow, so the resistive pressure will be there. Alveoli started to filling, so alveoli gives some elastic pressure. At the end of inspiration, you see that the peak pressure is a contribution of both. It's a resistive pressure and the elastic pressure. Okay. So what happens if resistance is increased or my elastic load is increased? How the pressure waveform will change? Okay. So in the volume control, I already told that volume is a constant flow irrespective of my resistance. So if I want to know if resistance is increased or elastic, the compliance is decreased, I have to see the pressure waveform. So here is the example, my resistance is increased. Something is related to tube block or tube narrowing or excessive secretion because of the tube size tube diameter is decreased. So when a flow occurs, it increases the resistance. How the ventilator waveform will change? Okay, this patient is normal. This is the patient's normal pressure time scalar. This patient, because of the secretions, the tube is thick secretion, the tubing is narrowed now. So what happened? The resistance will increase. So at the flow reach the maximum, it's 60 liter. If example 60 liter, the pressure compared to this, it is increased because the tube is now narrow now, the resistance is increased. So the pressure will, the same flow, the pressure is increased now. So during that, the whole inspiration, the pressure is high. At end of inspiration, the peak pressure is, before it is, example, it is peak pressure is 23, now it's 40. Which means that if it is a resistant, my peak pressure will rise. Okay, one. Second thing, if example other way around, it is because of the patient is on ventilator with CAD patient on ventilator. Now suddenly patient had some NSTEMI. Because of that NSTEMI, non-ST elevation, now ST MI, patient developed pulmonary edema. Now the complaints will decreased. But because of the volume control, irrespective of complaint, the same tidal volume, same flow will be delivered to the patient. So these complaint changes I can identify it from the pressure waveform, because pressure is a dependent variable. Here the pressure, the initial pressure won't change. Here it's an example, this is a pulmonary edema patient. What happened? This is the normal. Okay. When the patient develop pulmonary edema, so that is there is not a resistant related problem. This is a compliance related problem. The first filling, the flow, once the inspiration starts, the flow goes to the lung. The alveoli are not started to filling. The first pressure is contributed by, this pressure is contributed by the resistant. There will be no increase in the initial pressure. Once the alveolar lungs started to filling, because of the pulmonary edema, elastic pressure is high. The pressure used to be higher than the normal. Normally it should be like that, but now it's increased because of the elastic. So when you see, interestingly, you see here, both the elastance, poor compliance are high resistance, my peak pressures are high, irrespective of that. How can I differentiate from this high peak pressure is because of the resistant or higher elastance. One thing you can identify from the initial pressure. See here, this rise only in the resistance, and if resistance is increased, the initial pressure will rise. Elastance won't increase the initial pressure. One of the way to differentiate between them. If the problem high peak pressure in the volume control mode is, it may resistant or elastance, we can differentiate from the initial rise of the pressure. It's second. So what are the other method? We all know that is the inspiratory hold method. For inspiratory hold method, whenever the normal, I already told the peak pressure is a combination of resistive plus the elastic pressure. If peak pressure is raised, means maybe it's related to resistive pressure is raised, or it's a poor compliance related to that. How can we differentiate that? There is a inspiratory hold, end inspiratory hold. We can give them at least few seconds of hold, inspiratory hold. So that time, if inspiratory hold means there will be no flow. There is a no flow, is a zero flow here, zero flow. So the whatever the pressure in the lung, this is not contributed by the resistive pressure, because flow is zero means the resistive pressure also zero. Whatever the pressure you are measuring, actually it is given by the elastic pressure. When I give the peak pressure, I give the inspiratory hold, the respiratory component is, resistant component is removed. So now the pressure is contributed predominantly, the plateau pressure is, it's a lung elastic pressure, respiratory system elastic pressure. If example, one patient's peak pressure is initially 23, now it rise to 40. Two other patients peak pressure is now 40. This patient I put a inspiratory hold. Now the pressure is dropped from the 20, from 40 to 20. Peak pressure is 40, my plateau pressure is 20. If it is other patient inspiratory hold, my from the 40 inspiratory hold, my pressure is dropped to the 35. So this 20 centimeter means that the pressure, when I the inspiratory hole, the pressure dropped from the 40 to 20 means it's predominant, this pressure rise predominantly contributed by the resistive component. So this here, it's the problem, the high peak pressure because of the high resistance. Here the peak pressure is 40, at the inspiratory hole it doesn't much changed, still it is 35. So the problem here is that high peak pressures because of the elastance related. This means a poor compliance. Here it is maybe increased resistance. It may be a COPD or it may be excessive secretions or tube block, whatever the cause. So in the volume control mode, from that high peak pressure may be elastance related or it may be a resistance related. From the inspiratory hole, is there a greater drop from the peak pressure to the plateau pressure, which means that the peak pressure rise might be, the reason for the peak pressure rise is high resistance. There is no much drop from the peak pressure to plateau pressure means that high peak pressure because of the poor compliance, which means that high elastance. One more important thing we should know from that, whenever that the resistance depends upon two things. It's a flow, high flow will give the higher resistance. So whenever I kept the volume control, higher flow, the resistance obviously will increase. We don't know it is the high resistance because of the increased flow or actually the patient having higher resistance because of the tube block or increased secretions. How can I know that? If I see the higher resistance in the both inspiration, high peak pressure associated with this expiratory flow also give the changes. If example, if it is high resistance, my peak expiratory flow will decrease. Okay. If I see the high peak pressure with decreased peak expiratory flow, which means that there is a resistance during the both inspiration and expiration, it is a problem with the patient. If I see the high peak pressure, but my peak expiratory flow is normal, which means that this high resistance because of the increased flow. Should not confused with. So the resistance depends upon two things. One, patient related factors. Second is the flow related. Okay. Whenever I seeing that high peak pressure in the volume control mode, which may be related to the high flow or it really is the problem with the high resistance. It's a patient's factors like tube block or secretions. If I see the peak pressures also, if my resistance is high, the expiratory flow will decrease. For example, expiratory flow is, peak flow is 40 liter normally. If it is high resistance, it decreases to 30 normal. So, if I see the high peak pressure with low peak expiratory flow, which means that there is a patient related factors because it's increased the resistance during inspiration and expiration. If I see the high peak pressure, my peak expiratory flow is normal, which means that it's not a real patient related problem. It may be the ventilator settings. You are setting a high flow. So second thing we all know about that compliance, we know stress index. Stress index means that it's a mathematical equation. It gives an idea about that non-constant elastance by interpreting the slope of the pressure time scalar. What is actually stress index? Normally, this is called that this pressure time scalar. Okay, normally it should be in volume control, constant square flow waveform, your pressure time scalar will be like that. Okay, so this is the resistive component, this is your elastic component, this is elastance, this is your resistance. Okay, so the slope of the pressure time scalar will give idea about how your elastance. So normally what happen, our elastance will be constant, that is compliance will be constant during your whole inspiration, which means that there is no recruitable lung. So it will be the flat pressure times, that slope will be, this will be, there is no concave or convex. What happened to this normal lung? When the patient on ARDS, we all know about that there is a sponge lung concept. This is on lung, this is on lung. So normally it will be some part of the dependent part of the alveoli will be collapsed. This is collapsed. some part will be partially collapsed, this part will be normal airate. Okay. So normally that our aim is to open this alveoli partially collapsed and the collapsed alveoli. Meanwhile, you should not over distend your opened alveoli. This is one of the normal ventilator settings should open your collapsed alveoli, should open your partially collapsed alveoli. It should not cause over distension of your anterior part of the alveoli. So what happened during the inspiration? If it is ARDS, during inspiration, the positive pressure goes, it's open your partially collapsed alveoli. So our lung complaints, new alveoli are opened now. So the lung complaints will increase. Actually, the elastance will decrease. So if your lung complaints increases in the same flow and same tidal volume, your lung complaints is increased, your pressure will drop normally. Okay. So it commonly normal lung, your complaints will be constant during the whole inspiration, but which is not true in the patients with ARDS. For example, here that my slope of the pressure time scalar is linear. Okay. So which means that my lung complaints is constant during the whole inspiration. Next is that there is a downward concavity. It means that my complaints is decreased. If example, so this is my normal inspiration, my lung complaints is very linear in nature. My lung complaints is constant, so the pressure time scalar slope is linear in nature. Next is that my patient is already hyperinflated. Okay, if I give the positive pressure ventilation or increased PEEP, what will happen? It will cause over distension of the alveoli. If it is over distension, what happen? My complaints already that balloon can fill with only 500 ml. Okay. So I am increasing more than the 500 ml. What happened? The pressure, the wall of the balloon pressure will increase. So what happened to that during that over distension, which means that already lung is inflated. If I give the more pressure in that pressure, the wall pressure will increase. So in the same tidal volume, what happened to that? If a slope is linear, which means that compliance is constant. If my compliance is decreased during inspiration, the pressure will be increased. So the downward concavity, which means that stress index is more than 1, which means that already it is a over distension. You have to come down on your PEEP or pressure. If it is other way around, it's a upward concavity, which means that stress index is less than 1, which means that during inspiration, new alveoli are opening, which means that it's a recruitment is happening, which means that there is lot of alveoli are partially collapsed. During inspiration, they are opening up, which means that there is a lot of space to increase the PEEP. So if it is upward concavity, that is recruitment is happening during inspiration, you can increase your PEEP. If it is a downward concavity, the stress index is already more than 1, have to come down on your PEEP. It is 1 means that linear. If it is a slope is linear means there is a compliance is constant, there is no need to increase or decrease the PEEP. So you should not confuse. Stress index is a mathematical equation. It expresses the non-constant elastin, which means that during inspiration my elastin is increasing or decreasing. Okay. So from how can I know it is increasing or decreasing? From the slope of the pressure time scalar. Okay. If it is linear means there is no recruitment, there is no over distension. If it is downward concavity means it is over distension, have to stress index is more than 1, have to come down on your PEEP. If it is the upward concavity means there is a lot of recruitment is happening during the inspiration. That means that during inspiration the alveoli are opening up. So you can increase the PEEP to prevent the opening and collapsing. So should not confuse with that. There is stress index you can see in the pressure times slope of the pressure time scalar. To see the stress index in the pressure time scalar, patient should be on the Valium control mode. Second, the flow will be a square flow waveform. There is a constant flow waveform flow. Third is the patient should not take spontaneous breaths. Then only you can see the stress index From this stress index, we can know that you have to come down PEEP or you have to increase the PEEP or you can continue the same.